my distinct pleasure to introduce a long-term collaborator, continued collaborator, Dr. Asa Radix, who is a senior director of research and education at Callen-Lorde Center, with other roles. In particular, he's a professor of medicine at NYU Grossman School of Medicine. And he's also affiliated with us as an adjunct professor of epidemiology here at Columbia University. He's a clinical expert in transgender medicine, especially among transgender of color. And he's worked with me on several projects. He did his MD in internal medicine and infectious disease, as well as obtained his PhD in epidemiology here. He's an internationally recognized leader in transgender health medicine with more than 20 years of experience providing gender-affirming care to transgender and gender-diverse populations. So I'm excited to introduce his talk today, titled Transgender Health in the 21st Century, Epidemiologic Theory of Medicine.
Long introduction. I gave you one sentence, but thank you very much. To be able to talk to you today about my research, how I do the research, and maybe to think about together about some future projects we can do. So hopefully this is going to work. Oh, here we are. Oh, I see it now. Thank you for inviting me. So what I wanted to do is to just give you, I know you heard a little bit from but just talk a little bit about, again, my background, relevancy of my research, past and current research, as well as ongoing collaborations. If we have time, we can talk about perhaps some future projects, and then there'll be time for questions. But I really wanted to talk about what I trained in medicine in the West Indies, and I studied technology in Cambridge. And, of course, I came here to Columbia and got my PhD. But most of my work has really been with me being a clinician. I always say I'm a clinician first and everything else. So I did an infectious disease fellowship at UConn, and then I went straight to the Caribbean, where I was an epidemiologist and head of public health. And as you heard, I now work at the Callen-Lorde Community Health Center, and you've heard about my faculty appointment. The one thing about Callen-Lorde, if you don't know, it's one of the only centers that provides care to the LGBTQ communities and people living with HIV. So a lot of my work is based in sexual and gender minorities. So when you're talking to people, to find out like what drives them, what's the motivation. And, my interest working in the field of transgender medicine, because that's mostly what I do, came out of my early work as an infectious disease doc, working in the early 90s, when there really weren't any, highly effective antiretrovirals. And, at the time, and, I think of this often, I started to see transgender women coming to me in vast numbers. I was also seeing cisgender, gay, bi, and queer men, but I was seeing transgender women at a time when no one was talking about it. So what I started to do was incorporate gender-affirming care into my practice, started providing hormone therapy when there really weren't many guidelines and we weren't being taught about it. So that's really how I started working in transgender health. And, over the years, I became, a so-called expert in transgender healthcare. I've been a contributor and author to all the major guidelines. I just finished chairing the WPATH standards of care, but clinical practice informs gaps in research for trans and gender diverse people. And I'll say that, despite being called, an expert, there's not a single day that goes by that I don't find myself pondering a clinical dilemma that we need research to address. So again, that's the why I do this. So I'm thinking about, gender-affirming medical interventions. For those of you who aren't familiar with it, I just wanted to do a really quick slide. We call this like the standards of care. We generally have, feminizing regimens and masculinizing regimens. So feminizing would be, for someone who's assigned male at birth, getting hormones like estrogens or androgen blockers, also getting chest and breast surgeries, usually breast augmentation, having facial surgeries and genital surgeries. So this would be, removal of the testes, removal of the penis, having, a vaginoplasty or activation of the vagina. So These are all things under that umbrella. Masculinizing include, hormone therapy, like testosterone for someone who's like female, chest reconstruction, usually a mastectomy. There's also facial surgeries and there are genital surgeries. So there's a whole host with, not enough time, but I'm happy to talk to folks about this. But, it's really important what's available, because people who undergo these interventions are going to have an impact on their physical health and their mental health as well. And, those are the questions that I want to answer. So why is this important? Why is this field important? I think, first of all, we have to know the scale, right? So there are about 25 million trans and gender diverse people worldwide. And in the USA, we have recent data showing about 1.3 million adults. We know that upwards of 60%, in some studies even more, have access to these gender-affirming interventions. So, using this to reduce gender dysphoria, improve mood disorders and so forth. We know that, again, that there's going to be an impact on factors such as metabolic parameters, cardiovascular risk, bone health, cancer, fertility, and mental health. So there's still many important questions that exist regarding the direct effect of these interventions on health. And I'll just give you an example. If you have someone who's, a person assigned female at birth who's had testosterone and has had, a mastectomy, how do you approach? If you have a transgender woman, again, who's maybe has a vaginoplasty and she's been on estrogen, what box do you check when you're doing a cardiovascular risk assessment? Because there are a lot of sex-based algorithms and we don't know how to address that. So those are the kinds of questions that my research hopes to answer. So I wanted to say, this is a key issue. I mean, there's a lot of funding in the pipeline for this type of research. I mean, we know from the National Academy of Medicine, basically says everything is fair game. All aspects of the evidence base for transgender specific healthcare needs to be expanded. So definitely anything that intersects with the standards of care. There's really so little data available. Was, conducting research, within trans communities. And, historically there've been a lot of limitations in the types of research that we can undertake. And it's due to many, many factors. And I think the first thing is the fact that we're dealing with a very low prevalence population. The estimated prevalence of people who are trans is anywhere from, depending on the studies, anywhere from 0.4 to 0.6% in the population. I think the other thing that I'm sure you're well aware of is the high rates of discrimination and social marginalization, including in clinical settings, means that people experience a lot of medical and research mistrust. So engaging folks in research can be really quite difficult. Also,
don't worry about it.
Okay. The other thing I wanted to point out was that the early studies mainly used non-probability sampling methods. For example, single source recruitment, trans events, pride events, respondent-driven sampling, internet recruitment, and so forth. Then they became, like in the 1980s, the gender clinics that had started up, for example, in Amsterdam at the Free University Medical Center, started, doing retrospective chart reviews and looking at outcomes in their patients. And they started very small. You can see it. They started with about 400 patients, and it's grown over time. So those are the very first studies. More recently, and I would say in the last 2 decades, we've started to see cohort studies, multi-site cohorts, for example, using the Veterans Administration medical centers. There's also Kaiser Permanente, has a strong cohort. There are some new multi-center cohorts, for example, the NEG study, which is Europe, Tel Aviv, in Oslo as a site, and they've been publishing some fantastic work. The Legacy Project, which is a power center, it's Fenway Health and Callen-Lorde, there's a light cohort. And of course, we have the first probability sample, which is Transgender. And I won't be talking too much about that today, but I just want you to know really how things have changed over the last few decades. Trust in research. So, I have specifically looked at, long-term outcomes for transgender people who are undergoing gender-affirming surgeries and other interventions. I've used electronic health records and large databases, insurance data to investigate transgender health disparities. And even more important, obviously, than just looking at disparities, is thinking about ways to reduce them. So looking at effective interventions to promote health equity. So a few things that I've done, for example, have been, designing and evaluating curricular changes for physicians and medical students. That's just talk a little bit about where my really my first current focus had started. So one of the first studies that I ever did in transgender health was a mixed method study of transgender New Yorkers, really to find out what were issues of transgender health utilization and what were unmet needs. So, eligibility, quite straightforwardly, people had to identify as trans and non-binary, 18 years or older, speak English and provide consent, and we recruited from, health professionals and also a short 10-item survey, which asked a host of questions, including demographics, insurance, and where people were getting their care. And then we conducted focus groups. And what we recognized from this, off the slide, so, we did descriptive statistics for the demographic variables and healthcare utilization, analyzed with SPSS. The focus group sessions were recorded, transcribed, and analyzed. You can see here the results. We had 50 people. Majority were people of color, 37% African American, 26% Latinx, and the rest multiracial. People identified on, as on the majority were transgender women, but as you can see here, sexual orientation drove me to investigate outcomes after surgery. Was that the predominant theme was about lack of access to transition-related surgeries. This was really the greatest unmet need, and there were many reasons. So insurance, financial, lack of competent surgeons, fear of discrimination. But the thing that really startled me as a clinician was the fact that people were going out of overseas, they were going out of state to access care. And if they couldn't access care, then they were injecting silicone. And some were even attempting to do their own surgeries at home. So I had, it was just a moment that I thought, we have to do better as clinicians, researchers, we have to do better. One, Beyonce's body, Kobe bodies. Well, the second interest that I had in surgeries and gender affirming surgeries was, during when I was a doctoral student, during my dissertation, I was trying to think, what do I want to look at? And I thought, no one has ever done a scoping review of healthcare outcomes for people who've undergone surgery. So I decided to look at health outcomes for women who had undergone vaginoplasty. And you can see here, the aim was to investigate health outcomes after genital surgery, specifically vaginoplasty, which is a creation of a vagina using different types of skin. You can use intestinal tissue. You can use, penile and scrotal skin. I mean, it makes a difference, but in general, wanted to look at postoperative complications, long-term health outcomes, and also quality. So you can see here, the criteria included English language papers published between 1956. Why 1956? This was because this is really when the first surgery started being done internationally. There are a few that had been done before, but like Casablanca, all these places that were doing it really started in the 1990s. So I wanted to start then, and it was through 2018. There were primary surgeries, not revisions. They had to be adults. And I used databases, you can see, and probably the most interesting thing was finding the correct search terms, because what I hadn't realized was that obviously the terms we use today aren't the terms that we used in the 1950s. And for example, transgender women were called transsexual men back in the 1950s. So sexually assigned, sex change anymore. So just looking quickly, we had over 3,100 citations, 605 were duplicates. We identified additional studies through a hand search of IJTH, which is the International Journal of Transgender Health. You know, in the early days wasn't PubMed index, so we definitely want to look at those. We 53 into, you know, post-operative complications that were general complications and those that were vaginoplasty specific. And vaginoplasty specific were really things like vaginal fistula, vaginal prolapse, and so on. You know, that wasn't really maybe the most interesting thing to me. What was interesting was looking at the outcome measures. So for example, over the years, people were looking at things like sexual adjustment. They were looking at aesthetics. They were looking at satisfaction with surgery, quality of life, and criminality and arrest. So apparently that was a way we used to assess whether or not surgery was successful. In Markland that used this scale, which is actually still being used in some centers. So the idea was that when a transgender woman had surgery, she completely disappeared. She only associated with transgender people, you know, melted into the environment of neighborhood and friends, never, you know, completely cut herself off, which has ramifications for research, right? Because they never came back. People who did not adjust well, you know, where the surgery was a failure were, you know, you can read it here. Striptease dancing in gay bars, multiple arrests, and so on. So, you know, it reflects times though. So, you know, the other thing about measures is that you can see there were quite diverse. There were many different measures that were used. And I think the key point here is that none of these measures have been validated in trans populations. And this is another area of research that luckily Dr. Duncan is moving forward with. The scales that looked at function was the female sexual function index. And if any of you know what that is, in that scale, they ask one of the questions of vaginal lubrication. If you have a vaginoplasty with skin, with penile and scrotal skin, it does not lubricate. So the scale is completely off, right? So we have all of these studies using scales that were never validated. But I could say the same about all of the scales here. Thinking about outcomes for people who had surgery, there were many methodologic issues, including lack of uniform measures, including medical outcome and quality, lack of validated scales for transgender populations, and really a need to consider prospective studies with longer follow-up, because most of the studies, about 70%, only have follow-up up to 6 months. And thinking about how to validate all of these measures. Also focused on gender-affirming surgery outcomes was a global survey that basically asked surgeons, what are you telling your patients? What are you recommending before people, you know, come in to see you before they have surgery. So you can see here, the aim was to investigate the current scope of preoperative recommendations for trans and gender diverse patients planning gender. So specifically, we wanted to look at the areas that we're always debating, like preoperative or not, because people worry about the risk of blood clots. What about BMI? Does it really impact the safety of the surgery? So can someone be overweight or obese and have a vaginoplasty? What about tobacco use? You know, I think it's a wonderful thing. Should people be using that as a, no, I'm not going to. All things that are in the standards of care. What doing in real life. So, you know, what we did here, you know, I designed a qualitative survey. It was distributed to surgeons and medical providers to assess trans people for surgeries. The recruitment was social media, the paths are Professional Association of Transgender Health. So there's a world professional, there's a US, Europe for the E, there's ANSPATH, which is New Zealand and Australia. DR path is Brazil, and path is South Africa. So all the listservs got this. There are not a lot of surgeons who do this work around the world. You can see here it was in 2020, and it was so all country of practice. And then what do you do with these recommendations? And it was for each surgery. So you might have a recommendation, for example, for someone having breast augmentation, and you might have a different recommendation for yourself for someone having vaginoplasty. So it was really to kind of gauge. And, you know, we obviously don't have a lot. Just to show you a couple of the results. So we did 12 countries respond, which was great, and 135 surgeons, which was amazing. Most actually had a lot of experience in gender affirming surgery. You can see here 10.62 years. Most of them were plastic surgeons, but there were also some OBGYNs who were doing gender affirming surgeries and urologists. And you can see here that, you know, about a quarter had had formal training, but the majority of people who are doing these surgeries have very informal training. There are some people who would, you know, actually wrote notes, you know, basically looked at surgeries on the internet and figured out how to do it in their country, which was a little scary. So, but it was, you know, I think it was slide. So this is one example. What is your usual maximum BMI, body mass index recommendation for trans men having chest reduction or mastectomy? You would think that everyone would just say this is supposed to be, but I just put that slide up because you can see everyone have a different answer. And this is why it's so difficult to do research, because every project is right. So yeah, 68% had a BMI requirement, but the range was 25 to 46. Recommendations for hormone cessation for trans feminine patients undergoing vaginoplasty. So this is a really hot topic for the community, because when you tell someone they're going through the biggest moment of their life, having surgery, very emotional, and you're going to take their hormones away right before they, you know, maybe a week, 2 weeks, sometimes 8 weeks, it really sets people up. So you know, it was really interesting and sad to see that without any basis, people were stopping hormones as much as, you know, over 6 weeks before their surgery. But you can see the average was, you know, close to 2 weeks, and the range was 1 to 6. Research opportunity. There's a huge lack of consensus for preoperative management of trans people having gender affirming surgery. We need to have uniform guidance, and we need to really have additional research to guide expert opinion, because we need to know, you know, what's happening. We can't extrapolate from like cisgender people and our contraceptives and so forth, but we really need to have the data. So this is one surgeon wrote, you know, I follow our lead surgeon's guidelines, but would be willing to change if evidence suggests otherwise. So I do think that we could really make a difference. the other area that I've been working on is, using electronic health records and also other databases like insurance to investigate transgender health. So I just wanted that I led, which was the Transgender Data Project, which was really to figure out, health outcomes for transgender diverse folks. And this specifically was looking at HIV prevalence. Using an algorithm, because we, at the time, and still, it's very difficult to identify people in electronic health records. So one of the things that, we've always told people to do is, use a two-step question, what was your, assigned sex of birth and what is your gender identity? And you think that's wonderful and everyone's going to fill it out, but most places haven't figured out how to operationalize it. So either the questions aren't available on the registration form, or if they're in the registration form and someone fills it out, it doesn't make it into the electronic health record, right? So it can be very, very difficult to figure out how many trans people you have. And if you think, if you're dealing, you may have 1% or 2% in your health system, it can be very easy for folks to get lost. So, again, the aim was to examine HIV prevalence and its association with socio-demographic and risk factors and receipt of gender-affirming care among trans-masculine individuals. So as part of this, I developed an algorithm that we have used in other databases, which uses multiple pieces of data, right? We restricted this to folks who are ages 18 and up. So the first thing we did was use ICD codes. Now, ICD codes have been used in other places, but if you think about it, ICD codes are usually given to people when they ask for transition care. So if someone comes and is like, I want to start estrogen or I want to start testosterone, you may hopefully put the code in. But if there's someone who's trans-identified, doesn't actually want, gender-affirming care, they may be like, it's not for me right now, no code goes in. The same thing happens with surgeries. No surgery, no code, no referral, no code. So ICD codes are going to miss people, and they're predominantly also going to miss people who are non-binary identified. And I should say the study also included people assigned female at birth on the transmasculine spectrum. So it's, those folks often aren't identified. So another way you can look is obviously if someone's legal gender and their assigned birth sex is different, and you can usually find this again in electronic health record in different places. Someone, self-report that they're trans, so you can, natural language processing. You can sometimes pick up phrases and pick up words in the chart. A discordant legal name and a preferred name is another way. But some people are. Elizabeth goes by Beth. So, you may pick up cisgender people that way. And then, of course, the other way was someone who's a designated female receiving testosterone. That was another way. So what we did was we that had any one of these points positive. And then we did manual chart reviews on every single chart with 2 reviewers to verify birth, sex, and gender. We're able to identify just about everyone. So, for the analysis, we were looking at HIV prevalence, but in order to do that, you need to have people who've actually had an HIV screen. So we use t-tests and chi-square tests to look at different ratios to estimate for associations between HIV status and socio-demographic, behavioral, and health variables. When looking at HIV prevalence, we did a multivariable logistic regression, which included age and any variables that were significant at B less than 0.1 in the bivariate analysis. And the model included 220 cases, did a goodness of fit test, and then all p-values are two-tailed with a significance level of 5%, and we used so hopefully you can see this here. So, we were able to identify 577 transmasculine individuals. The HIV prevalence was 2.8%, which actually is in line with what we've seen in other studies. Just a few other points, the majority, very high numbers had used testosterone. Not surprising because people were engaged in medical care. And about just under half had any gender affirming surgeries. And I should say the majority of those were mastectomy. And we compared variables between people who were HIV screened and who weren't. They actually look very, very similar. And you can see here, what you might find surprising is that by race and ethnicity, just under half identified as white. They were very well educated. I mean, many with bachelor's degrees and graduate degrees. And I think, we also looked at similar numbers, data for people who were identified as transgender women and trans feminine. And so very, very, very different. So, folks were employed with stable housing and so forth. But still, that's a shockingly high HIV prevalence. So, the other thing we wanted to look at, because we had a field that actually asked about gender identity as sexual partners. Now, obviously, you can have more than one sexual partner. So, when asking this, people could check off if their partners were cisgender men, cisgender women, transgender men, transgender women, if they had no sexual partner and so forth. But they could check any number of boxes. And what we found, of course, was the fact that there was a lot of heterogeneity with prevalence, right? So people who had partners who were cisgender men only, the HIV prevalence was 11.1%. Yes, the numbers are small. If you look overall, but still, I think this was something that was important because what we've always heard in HIV research is that transgender men are not at risk for HIV, right? Because all their partners are cisgender women and we don't need to bother with them for HIV prevention interventions. So nothing, like no study had been ever being funded by NIH because there was this narrative that transgender men are not at risk. So this is the reason, of course, when we did the, bivariate analysis and then the multivariate analysis, you can see here that really is the fact that, again, having a cisgender male sex partner only was highly significant for having a diagnosis of living with HIV. So, I think this was, again, an area that added to the literature. After this was published, we actually did get something funded by NIH to create an intervention in transmasculine populations. So, again, I think that, there are huge public health implications. Again, the heterogeneity of HIV risk among transgender men. And that we really should be, instead of looking at categories, we should be looking at behaviors. So, really delving in, because, a transgender woman who identifies as lesbian, who has cisgender female partners, we can discuss HIV risk as we do with everyone and get people screened, but that shouldn't be the priority, right? And, obviously transgender men who have sex with men need to be included in HIV prevention efforts. And it really does, this really underscores the importance of not only collecting gender identity information, but finding out who people are having sex with and what their sexual behaviors are. So what we've had to do is shift, because do you have, in medicine, we ask people, do you have sex with men? Both, but it's not so simple, right? I have sex with a woman, she happens to have a penis. You really need to find out all the information. And there are many best practices evolving about how to do that. So wrapping up here, the legacy cohort, legacy project, and why it's important for us to have prospective studies, right? So we can actually evaluate these outcomes. So we have been working with Fenway. We have it's a two-site. Fenway is like the equivalent of Callen-Lorde. It's a clinic for LGBTQ folk in Boston. So we decided to see what we could do with our data, if we could create a research data warehouse, which sounded sounded amazing when we were thinking about it. It had many challenges, 2 different electronic health records, data, in different in the charts, not using the same ICD codes or many different things, but this was funded by FACP. And even though we really are just cleaning data now, I wanted just to talk a little bit about the aims. So this was really, again, as a prospective study. The aim is to evaluate the effects of medical gender affirmation on HIV prevention continuum and the HIV care continuum outcomes. The second aim was to examine whether medical gender affirmation predicts 12-month prospective improvements in psychological functioning and health-related quality of life in trans patients who are receiving gender-affirming hormone therapy, and also to look at whether improvements in psychological functioning and health-related quality of life mediate the effects of medical gender affirmation on HIV-related outcomes. And then there's a third aim, which is really to characterize patient satisfaction with medical gender affirmation, as well as future desires for an unmet medical gender affirmation needs and barriers and facilitators to medical gender affirmation. Intersectional lens, so we're also looking at race and ethnicity, right? And so just to show, aim 1, aim 2, and aim 3, and of course the aim 2.1, really trying to see if logical functioning and health-related quality of life really mediates that association between medical gender affirmation and HIV prevention and care outcomes. And we can look at a number of different outcomes. I mean, that was for the funding, but obviously we're looking at a little bit more, again, age 18 and up. This usually the trans care guidelines, like when we give people hormone therapy, there's a lot of debate, but in general, most sites are using 18. Folks who identify as trans and non-binary, an active patient, and that's so because we have a lot of biomarkers that we're using, HIV testing, STI screening, and so forth, we need those results, and then having a patient consent. I want to talk a little bit about ethics. So a lot of people, as I said at the beginning, experience medical mistrust, research mistrust. In our clinic, we are very transparent. We ask every single person if they want to be involved in research, if they want to hear about research, and they sign a form when they register. We don't just use people's data without consenting, because a lot of researchers will get a waiver of consent because it's really difficult when you want to do the study and it's not possible really to consent everyone. But we decided to we have decided to do that, and it's really important. I think this is the last slide, but just showing you what we're doing. Gender therapy by interest of outcomes. We're looking at STIs, PrEP uptake, viral suppression at baseline in 12 months, the descriptive statistics, to summarize the variables by site, bivariate tests, examine differences by site, and we're also adjusting the site differences by including site as a fixed term. I'm going to 1 minute. I just want to just say that, there's other research that I'm doing, again, really tied to my interest in intervention. So I've done research in transgender with transgender physicians and trainees, shocking results, people being afraid to access medical care, high rates of suicidality attempts. We're also now trying to validate measures about patient satisfaction after gender-affirming surgeries using patient-reported outcome measures. I just want to put this slide up. I do a lot of collaborations with faculty here at Columbia, and all in the area that I'm interested in. And I love, I've had a wonderful, it's very, very exciting, the work that we're doing. And then there's some new projects that are coming up. Folks here at Columbia, some with other folks, and want to highlight this. And I think this is my last slide. So I just also want, I am very interested and excited about teaching, service, and mentoring. And you can just see the slide. I keep very busy being involved with teaching medical students, residents, IB fellows, MP students, and PhDs in many different areas. And also service on a city, state, national, and international level. And also mentoring doctors. So I just want to thank you for your attention, and I hope you enjoyed the talk and you have lots of questions.
The first is the measures that you evaluate for the applied. Did you differentiate those measures by the different types of operations, surgery, and investment procedures? And number two, I wonder if you could talk a little bit about whether or not there is a competing interest or competing opportunities among the population between getting, gender affirmative care versus HIV prevention. There's a difference between transport management.
So there's been a lot of research and repeat the question. So the question was, I'll start with the second, I'll repeat, competing interests with either HIV prevention and treatment versus gender affirming care. This is very true. When I mentioned at the beginning that we had done, a mixed method study and done focus groups. These survey, for example, whether people had been screened for HIV, if they knew their HIV status, and we asked questions about STIs on that survey. When we were in the focus groups, every time we tried to bring up a question about STIs, HIV, subject, no one wanted to talk about it. The only thing people wanted to talk about were access to gender affirming care and specific services. So yes, I mean, this is the reason why, for example, there's a study right now, which is the HBTN 091, which is looking at co-located care versus, people getting their HIV, like HIV prevention care and hormones separate. We believe that this care should be provided in the same place because no one to make the choice to go to a clinic for their HIV prevention medication if they have to go to another clinic for their hormones and they only have one bus fare. Gender affirming care is life and death for the who want it. It is so important that it so you have to accept that. You can also use it in clinical care. You can use it as a way to engage people in care. So yes, so this is, we have a study now that's going to actually assess this, evaluate it, and tell us hopefully what we need the evidence, right? Because the problem is I'm just going to just say this, a lot of places in many countries that are providing, HIV prevention or HIV treatment will not also provide gender affirming care for many different reasons. And that's why we need the research to really make this. The other question you had was about metrics, measurement, different measures. The reality is no measures, a few now, but almost no measures have been validated in trans populations. And I'll give you another example, and that is alcohol consumption. When you assess someone for alcohol use, there's how many drinks you can have if you're a woman, and how many drinks you can have if you're a man, right? And then, so that's the first thing, how many drinks, right? What do you do? We know that hormones, especially estrogen, actually change the body's physiology, right? People who are on estrogen actually don't have the tolerance for alcohol that they did before they were on estrogen, but no one is examining them, right? Another area of research that needs to be these scales, and we don't. So every scale, if you think that they can be, especially if they're sex-based scales, I gave you the one like alcohol, or another's kind of outcome that you probably are aware of is like spirometry, right? So when you go to get your pulmonary function test, like to see if you have asthma, or you see, the first thing they do is they check the box that says MOM, because traditionally someone, who assigned male at birth has a larger chest volume. So if you put the wrong marker, you're going to see the same thing. PGs. There are so many different areas that need to be validated. As I said, this is an area of research that is never going to close, I think, and it's not for research sake. We have to provide better care. When I talked about research as being a way to promote health equity, I'm not just saying that. It is really, really important that we have the person in front of us and we provide appropriate evidence-based care to ensure that they have, a healthy life. I mean, what we're doing right now by ignoring these issues, it's just terrible. Okay, I'm sorry, I shouldn't have spent so much time on that. So let's see. Okay.
For such a talk. I may have missed it when you were presenting the analysis of the insurance data. Where did that data set come from? Which kind of insurance? Do you think you would find similar results if you looked at a different insurance data set, and then related to that, what would you find if you don't make it into that data set?
Yeah, and as you know, that's very important. I mean, you automatically have a selection bias when you're talking about different insurances. So when you're thinking about people who have Kaiser Permanente insurance versus people who are getting their medical care through the VA centers versus people who are on Medicaid in New York, which is a database that I've worked with, and also the Medicare, I've worked with MarketScan as well. You're going to see differences, but I think the key thing is about how you identify people in the database. Once folks are identified, then you can start thinking about them. So it's all about the algorithms, right? Of course, if people aren't in care, never touching a healthcare provider is impossible to. And, unfortunately, we just don't know about the health of people who aren't in contact with us. I mean, there is some work going on right now, for example, in amongst people who are incarcerated, or those often folks aren't linked to care, at least when they're in carceral settings, and they are covered under often health and outcomes and so forth. But I mean, there are very few people doing the work. Actually, you always need to look at the data set and think about, think about the biases that it's going to, gender. So
This was from what kind of insurance?
no, I think I was this about the transmasculine folk and HIV? That was a clinic data set. Yeah, that was a clinic data set, which, so when I showed the insurances, she had broken it down by.
She's running some. Seems like trans health broadly. My question though stems kind of from my background. You said students are curious to hear, touched upon it, mentioned work in mostly marginalized populations. But can you give us a sense on what work you want to do in that space, and where the gaps are? I see huge gaping gaps, to be very honest, but I think it'll be helpful to just get a sense of that.
So a bit about where I want to go with this. And it's actually not in the US. Because I feel that, you know, when you look at the field of transgender medicine, it is very located within, it's North America, it's US, right? North America, Europe. You know, I'm from the Caribbean, you know, I see people who are like struggling to access healthcare. And I'm sure you know this, but if you look at transgender women living with HIV in New York City, a huge proportion of them are actually from Latin America and the Caribbean. You know, people like flee countries because of the harassment that they have. So, I mean, that is the areas, that's one of the things I want to do, like really go to place. I mean, some work has been done in Jamaica, but, you know, other areas that I've actually, you know, I'm often asking providers in places like, you know, Guyana, or the last place was St. Lucia. It's usually connected to like PEPFAR funding, you know, like they have to. Hope that they are invested. But there's so much work that needs to be done to look at the multiple layers of stigma that people experience and how it impacts on their health, right? So because no one is doing it right now. And yet the Caribbean, for example, has, you know, the second highest prevalence of HIV, you know, in the world, like after sub-Saharan Africa. And often, you know, occurring in populations, again, who are just not being counted, right? And if you go to a country like St. Lucia, or you go to a country like Guyana, or, you know, and you say, tell me about transgender people and their health, you know, I can tell you a decade ago, I heard, oh, we don't have it. I've been told that. You know, now, okay, people are ever. So I can talk, so the question is, can you talk about cancer screening? So, you know, in the healthcare utilization study, I've done 2 studies on healthcare utilization and cancer screening. And we've seen the same thing in both, and every type of cancer screening, right? But which is that trans and gender diverse people underutilize cancer screening. So whether it's colon cancer screening, cervical screening for people with a cervix, you know, breast cancer screening for people who had breasts or who have breasts now, it's just not done. And I think some of it, you know, and I don't know the answer because we haven't studied, we haven't done the extra studies on this, is that clinicians, providers don't know what the standards of care are. Standards of care are very clear. A woman of trans experience and you've been on hormones and you have breasts and you're 50 and over and you've been on hormones for 5 years, you should get screened, because yeah, there are, you know, your rate of breast cancer is 42 times higher than a cisgender. And we know this actually from imaging studies. One of the, this is why we need prospective studies, right? So why are people not getting screened, right? You know, for many transgender women, having a mammogram is very affirming to their gender identity. So that's not the issue. Yes, there can be insurance issues and there can be financial issues. The biggest problem that I see is providers are not, which is why I think that providers went offline. I've actually wrote like 3 of the key papers on screening, and it's also, you know, the I got to. And, you know, you can always email me. I actually have my email. I have a Columbia email.